Hello everyone, welcome to the quick medical revision series. The first topic of this quick medical revision series was the formation of atrial septum. In continuation to that, today we are going to know about the atrial septal defects. In this topic, I have tried to cover all the features which have been generally asked in the MCQs. So go through the series, and after this, I promise that you will be able to answer every question about the atrial septal defect. So let us start with the ASD. ASD, that is atrial septal defect, is one of the commonest congenital heart disease. Not the commonest, as per Davidson, the commonest is the ventricular septal defect. Now this is of three kinds: sinus venosus, ostium primum, ostium secundum type. To know about the ostium primum and ostium secundum type, go through my first lecture, that is the formation of atrial septum. It is more common in females as compared to males, and out of these three defect sites, sinus venosus, ostium primum, ostium secundum is the most common type. So 2 points to remember: one of the commonest congenital heart disease, females more common than males, and most common defect is ostium secundum defect. Now in atrial septum is made up of two parts, that is, one is the septum primum and thick rigid part septum secundum. In the septum primum we get a primary opening in the lower part known as ostium primum. A secondary opening in the upper part after closure of ostium primum is ostium secundum, and in septum secundum we have a opening, that is foramen ovale. And never confuse the foramen ovale with the septum secundum defect of the atrium septum. Now first is the sinus venosus. The sinus venosus type is a defect in the atrial septum, that is in the uppermost portion of the atrial septum, just near to the entry of the superior vena cava in the right atrium. And in this what happens, that the pulmonary vein, that is the right pulmonary vein which arises from the right lung, opens always into the left atrium. But here that right pulmonary veins from the right lung doesn't open into the left atrium, rather it opens into the right atrium at the junction where superior vena cava joins with the right atrium. So it is a defect in the uppermost portion of the right atrium, where the right pulmonary vein opens in the right atrium. It is a defect because right pulmonary veins opens into the left atrium. So this opens at a junction of superior vena cava with the right atrium. Okay, so this is the sinus venosus type. The another common defect of ASD is ostium primum type. This is a defect at the primum level, where ostium primum opening was present, that is present in the lower part of the septum primum. So this defect is in the lower part of the septum primum. It is a defect which lies in the lower part of the septum primum, just as adjacent to the atrioventricular valves. To understand this, you must watch my first video, that is formation of atrium septum. So this defect lies adjacent to the atrioventricular valves. It is a septal defect. It is associated with cleft mitral valve, remember this, and Down syndrome, remember this. So 2 points associated with cleft mitral valve and Down syndrome, and it is present in the lower part of atrial septum adjacent to the atrioventricular valves. Ostium secundum defect, most common type of ASD, mid-septal in location, where ostium secundum and secundum opening forms. It involves the fossa ovalis. Fossa ovalis is a depression in the right atrium where the foramen ovale is present in the septum secundum. So this defect involves the fossa ovalis. To understand this also, watch my first video. And this defect is caused by excessive cell death or reabsorption of septum primum, or inadequate development of septum secundum, and should not be confused with the foramen ovale. So most common ASD, mid-septal in location, and involves the fossa ovalis. Now things to remember further: in ASD there forms a left to right shunt. After birth, when the lungs starts functioning, the left heart pressure is more than the right heart. Similarly, right atrium pressure is more than the right atrium pressure. So during the contractions of the heart, when the left atria contracts, or because of the increased pressure in the left atria, the blood moves from left atria to right atria via these septal defects, that is ASD. So here in ASD we have the left to right shunting. Now the magnitude of that shunting, that means how much blood will pass through from that shunting. So that magnitude of shunting depends upon the size of the opening, the diastolic properties of the ventricles, that means when the ventricles are relaxing, the arteries are filling, and the effective resistance at the level of pulmonary and systemic circulations. So pulmonary level, the more the resistance at the pulmonary level, more will be the resistance developed in the right ventricle, more will be the pressure developing in the right atrium. So those pressure changes will determine the magnitude of shunting. So that magnitude of shunting depends upon pulmonary pressure area or pulmonary circulation pressure as well as the systemic circulation resistance. So more the resistance is created at these places, more the resistance generates at the back places. So three things: size of opening, diastolic property of ventricles, and the effective resistance of the pulmonary and systemic circulation. It is asymptomatic in early life, frequently missed in childhood. Just the symptoms we see are nothing but the physical underdevelopment and increased tendency for respiratory infections. So whenever a child comes for increased tendency for respiratory infections, always examine the cardiac system. You may find the murmur of atrial septal defect. Beyond 40s, the patient may develop atrial arrhythmias, pulmonary arterial hypertension, and right to left shunting of the blood, and then the cardiac failure. So earlier it was left to right shunting, from left heart to right heart, left atrial to right atrium, the blood was shunted up till, or in the adult age or in the 40s, that shunting may reverse. It may move from right to left. And why this happens? This happens because with continuous shunting of the blood from left to right, and because of that shunting, the right arterial overload, or the blood in the right atrium increases up, or right atrium needs to bear a more load. That load transfers to the right ventricle. From right ventricle, that overloading transfers to the pulmonary vasculature and leads to pulmonary congestion, and because of that pulmonary congestion, the resistance develops in the pulmonary area. Because of that, the pressure generates more in the right ventricle. That passes back to the right atrium, and as a result, the right arterial pressure exceeds the left atria, and there starts the right to left shunting. And when the right to left shunting starts, the impure or unoxygenated blood mixes with the oxygenated blood of the left atrium, and at that time cyanosis may develop. Now the physical examination. In physical examination, you must remember, one, the heart sound 1, that is the first heart sound, is normal, absolutely normal, or it may split. So remember, first heart sound is normal. The second heart sound, this question is generally asked in MCQs. The second heart sound in ASD, it is the only congenital heart disease where the second heart sound is widely split but fixed in relation to the respiration, in relation to the inspiration and expiration. So whenever this question is asked, remember, the second heart sound is widely split and fixed in relation to the respiration. Then the murmurs. Remember, murmur here in ASD will not be because of the shunting of the blood from left to right from the septal defect, but the murmurs will be because of the overloading or overflow or excessive blood passing through the valves, that is the tricuspid valve and pulmonary valve. Why? Because there is a left-right shunting. The excess blood from left atria moves to the right atria. From right atria it becomes overloaded. It passes its whole blood to the right ventricle to the pulmonary area. So the murmurs arise because of the passing of this overloaded blood through the tricuspid valve and through the pulmonary valve. So one murmur when this excessive flow of the blood through the pulmonary valve will be a systolic murmur, that will be the mid-systolic pulmonary ejection murmur due to increased blood flow across the pulmonary valve. So one is the mid-systolic pulmonary ejection murmur. Then because of the increased blood flow through the tricuspid valve, that will be the diastolic murmur, mid-diastolic rumbling murmur, and a holosystolic murmur, that is a pansystolic murmur in complete systole. This pansystolic murmur will be there in the OSTIUM PRIMUM defect, and that will occur because of the mitral or tricuspid regurgitations. So three kind of murmurs: mid-systolic pulmonary ejection murmur through the pulmonary wall, mid-diastolic rumbling murmur through the tricuspid valve, and pansystolic murmur in OSTIUM PRIMUM defect because of the mitral regurgitation. And remember these points also. The mid-diastolic rumbling murmur will be loudest at the fourth intercostal space, and there will be a heave in the left parasternal area. So left parasternal heave will be there. These questions are asked generally in the MCQs. One is heart sound, second is widely split and fixed. Murmurs will be systolic murmur, pulmonary systolic, diastolic murmur through the tricuspid valve, and pansystolic in OSTIUM PRIMUM defect, and left parasternal heave in mid-diastolic rumbling murmur. Now, left to right shunt, gradually that shunting diminish, or the magnitude of the passing of blood from left to right atria diminishes with increase in the pressure in the right atria. And what are the features and how will you come to know that the shunting or magnitude of shunting has diminished? Number one, the pulmonary and tricuspid murmurs will decrease in intensity, because now there will not be overloading of the right artery and right ventricle because of the decrease in the shunting. So the murmurs of tricuspid and pulmonary will decrease in intensity. Two components, heart sound 2, which were split, widely split, and which were fixed, now there is no split. They may fuse, there may be just a single second heart sound, and the murmur of pulmonary regurgitation may appear because of the increased pulmonary congestion till that time. So there may be a pulmonary regurgitation murmur, and pulmonary regurgitation murmur will be of diastolic in nature. Clear? So these things will decide the diminution of left to right shunt. And when the shunt will develop into right to left because of the continuous increase in pressure on the right atrium, there will be development of cyanosis and clubbing. And when the left to right shunts reverse to right to left because of the increased pressures, that is known as AC Menger syndrome. Remember this, AC Menger syndrome is right to left shunting in left to right acyanotic congenital heart diseases. And when the right to left shunt develop, there occurs a clubbing and cyanosis, mainly because of the mixture of the unoxygenated blood with the oxygenated blood. Now the ECG finding. Remember the mnemonic ORS, the ORS solution: O for OSTIUM, R for right axis, and S for secundum. So OSTIUM secundum defects have right axis deviation, and those who have watched my ECG series, they know how to find out the right axis deviation from the ECG. In lead 1 we will be having negative complex, and in lead 3 we will be having positive complex. And OSTIUM PRIMUM has the opposite of OSTIUM secundum, the left axis deviation. In lead 1 we will be getting the positive deflection, and in lead 3 we will be getting the negative deflection. And in OSTIUM secundum we have the right bundle branch block pattern, that is the RSR pattern. You just see here the R pattern, S and R dash. This is the RS pattern we will be seeing in the V1. ECG shows the right atrium and right ventricular hypertrophy because of the left to right shunting, increase in the pressure in the overloading of the right atrium, right ventricle, and that leads to the hypertrophy of the right atrium and right ventricular. The ECG changes of right atrium and right ventricular hypertrophy will be there. I have discussed about the right atrium ECG changes in my ECG lecture series. X-ray will show the right atrium, right ventricular hypertrophy, as well as the increased pulmonary vascular markings because of the pulmonary congestion, and echo is the diagnostic of the AST. Treatment part will be operative closure of the shunt by a patch of pericardium in children between 3 to 6 years of age is recommended in all where there is a significant left to right shunting. So if there is significant left to right shunting, even if the child is asymptomatic, he should be operated between the age of 3 to 6 years of age. No operation is required for small septal defects or very trivial right to left shunting. very trivial left to right shunting, or in patients with severe pulmonary vascular disease without significant left to right shunting. So if the defect is very trivial, there is a mild left to right shunting, no operation is required. But if there is a defect which is of larger opening and there is even if there is no symptom but shunting is significant, the operative closure is to be opted out. So thank you so much and have a nice day. I hope you have understood. I have covered all the key features, all the points generally asked in MCQs. Thank you.